Hello everybody, I am Divyanshoo Kohli from Sacred Heart Medical Center from Spokane, Washington. Thank you to the ASGE and the Gastrointestinal Endoscopy Journal for the opportunity to present our work. The title of the study is Comparative Accuracy of Endosonographic Shear Wave Elastography and Transcutaneous Liver Stiffness Measurement, a pilot study. I am presenting on behalf of my co-authors, Doctors Daniel Metman, Naveen Andros, Erin Hare, Jamie Porter, Aslam Usarach, Steve Allery, Madhav Desai, Mohammad Siddiqui, and Pratik Sharma. This is an investigator-initiated, industry-supported study. These are my disclosures. NAFLD is the most common cause of chronic liver disease, and hepatic fibrosis is the most important predictor for disease progression and outcomes. A liver biopsy is not feasible in all patients with NAFLD, and hence there is a need for alternatives. The most commonly used alternative methods to assess for liver fibrosis include lab-based markers such as the NAFLD fibrosis score, FIB4 or APRI, and transcutaneous elastography, either using an ultrasound or a fibroscan. Another recent modality is MR elastography. But the most commonly one used is a fibroscan or a vibration-controlled transcutaneous elastography or VCTE. The problem with VCTE or fibroscan is that its performance in patients with morbid obesity is suboptimal. In these patients, it has a low positive predictive value, and even the extra large probe is unreliable in about 35% of these patients. Patients with narrow intercostal spaces or an increased distance between the skin to the liver also are difficult to assess using a fibroscan. And then finally, fibroscan only assesses the right hepatic lobe, and hence regional variations may be missed. Another alternative to this is the EUS guided shear wave elastography. Using an endoscopic ultrasound, a direct real-time visualization of the liver parenchyma is feasible. An optimal spot can be assessed for measurement. EUS shear wave elastography tends to work in patients with morbid obesity. It has no impact of intercostal spaces, and the endoscopic ultrasound can be positioned over the left or the right lobe. The primary outcome of our study was to assess the diagnostic performance of EUS shear wave elastography for advanced fibrosis. We used histology as our reference standard. Secondary outcomes included assessing the accuracy of EUS shear wave elastography and comparing the left and right lobe using an EUS, and subsequently comparing EUS and fibroscan for technical success, moderate fibrosis, advanced fibrosis, and cirrhosis. A little background about EUS shear wave elastography. It provides us with two measurements. One is the E-value, which is a surrogate for liver fibrosis, and the other is the VSN, which is a quality of exam indicator. An EUS shear wave elastography measurement is adequate if the VSN exceeds 60%, and the technical success is defined by the ability to obtain a median of 10 E values, each of which has to have a VSN exceeding 60%. This is how the EUS shear wave elastography looks like. You can see the liver parenchyma, and there is a rectangular yellow box which is the region of interest. On the top right, you can see 10 measurements which include the E value and the VSN. Higher the E value, more the fibrosis, and a VSN exceeding 60 is appropriate. Our protocol included assessing patients with suspected liver fibrosis and performing an initial workup. If that initial workup was unrevealing for fibrosis, then patients underwent a fibroscan and an EUS shear wave elastography of the left and right lobe. We also obtained liver biopsies of the left and right lobe for further comparison. In about a fifth of the patients, 19%, the VCTE or fibroscan was unreliable. On the other hand, EUS shear wave elastography was successful per protocol in 100% of the patients, including those in whom fibroscan had failed. For the left and the right lobe of the liver, we were able to obtain liver stiffness measurements, and the VSN percentage exceeded 60% in all measurements in both lobes. We used the AUROC curves to assess the diagnostic accuracy for FibroScan as well as shear wave of the left lobe and the right lobe. And we compared these for all degrees of fibrosis, that is significant fibrosis, advanced fibrosis, and cirrhosis. There was no significant difference in the area under the receiver operating characteristic curves for any of these modalities. So VCTE shear wave of left and right lobe had comparable diagnostic accuracy for all grades of fibrosis. In terms of sensitivity, FibroScan and EUS of the right lobe had comparable sensitivity for advanced fibrosis and cirrhosis. For specificity, EUS of the left lobe had a higher specificity than VCTE as well as the right lobe. Notably, both of these did not reach statistical significance. It is important to bear in mind that EUS shear wave elastography is an invasive procedure with associated risks. It has an associated cost as well, but it can be combined with standard of care endoscopy as part of the burgeoning field of endohepatology. It is a useful adjunct in patients who fail a FibroScan. The study was limited by the fact that there was an abundance of older men. This was a study performed in veterans. There was a selection bias due to which there is a higher prevalence of advanced fibrosis than what would be seen in patients with NAFLD. There was a higher percentage of patients who failed a VCTE or a FibroScan. And we also could not exclude coexisting liver illnesses. So some patients also had a history of hepatitis C, for example. Despite these limitations, it is notable that EUS shear wave elastography correlates very well with histology for degree of fibrosis. It has an accuracy comparable to FibroScan, and it can be very reliably performed in patients who fail a FibroScan. So with that, I'd like to end, and I thank you for your time, and thank you to the GIE Journal for this opportunity.